An open discussion. Any question from the audience for the first lecture on superior capsule reconstruction with the fascia lata? Any question?
Well, is there any question for this from the people?
Yes, please.
Hello. I would like to ask how long approximately it takes to do it. Do you hear me? Can you hear me?
Not so well.
So I would like to ask how long it takes to do it arthroscopically, and what are the privileges comparing to the open? Is there a quicker rehabilitation? What's the approximate time for doing it?
It's a question for you.
Close.
Yeah.
For the first presentation.
Usually it's about 1 hour and a half, maximum 2 hours, including the harvesting. And I didn't understand if you're asking about the advantages of harvesting open versus minimally invasive and the rehabilitation of the thigh. The problem is the only study there is about donor side morbidity is ours with the minimally invasive harvesting, because Professor Mihata only mentioned in his papers that there were no complications. He did not do a dedicated study on the specific morbidity of the open harvesting, and there are I think 2 studies about harvesting, but really there are no studies regarding the specific problems of harvesting openly of an open harvest at the site where Mihata harvests. So we cannot compare the 2 techniques either regarding donor site morbidity or regarding rehabilitation. What I can tell you is about our technique. Yes, in our experience, our patients do not need rehabilitation for the thigh. We only recommend that they use compressive stocking for 1 month and a half, because this technique is not really original. It's a modification of another technique that was described by otorhinolaryngologists for harvesting fascia lata to do rhinoplasties. And they used compressive stocking for 1 month and a half, and we did this with all our cohort. And in principle, the idea is you're acting like a plastic surgeon. You want to avoid the hematoma, and you want to improve the healing of the defect you create with the harvesting of the 15 to 20 centimeters by 3 centimeters of fascia lata that you don't close by doing this approach. And the patients, in the end, what we showed in our studies was that they are either very satisfied or satisfied with the harvest site regarding function, regarding cosmesis, and the only thing, as I mentioned, that prevails for a long time is some numbness in the territory of the laterofemoral cutaneous nerve that subsides and is not a problem. And we, in our last study, we addressed this question with our patients, and this doesn't really bother them if it persists for a long time, and then it circumscribes and it eventually disappears. So they don't do rehab specifically, just avoid strenuous activities for 1 month, but what they don't need any support to walk. You can do this in an outpatient procedure. You can do. You just instruct your patient to be careful in the first day, but they can walk. They don't need canes to walk. This is not limiting, neither in the short nor in the long term. In fact, they don't have any limitations in the end regarding activity. So I don't know if I answered your question.
Do they start the next day?
Okay, we have to go ahead. I'm sorry. It's not a private discussion.
Okay. Okay, thank you.
Any other question? Yes, please.
For one.
Last month, Dr. Burkhardt and Dr. Michata comment on Arthroscopy Journal about either to you, Clara, about superior capsular reconstruction and the effect on pseudoparalysis. Can I have your comment about this? There is in the last month, in Arthroscopy Journal, Dr. Burkhardt and Dr. Michata referred their result with superior capsule reconstruction in cases with pseudoparalysis. And they have very impressive results. Can you comment on that? Do you have the same experience?
Dr. Burkhardt published a paper this year regarding selection of patients with pseudoparalysis, and they reviewed them and they did MRIs to control the healing of their allograft. That's the paper you're referring to. And they have the 70% healing of their allografts in this selective group of patients. What the comment I have to make regarding this fact is that they have a big cohort of patients, and they control the healing in these 10 patients. In these 10 patients, 70% of the patients healed. So I don't know in every patient if you have a high rate of healing of the allograft, and we also don't know if there is any clinical correlation between allograft healing and the clinical outcome. So the comment I have to make regarding this is that these 10 patients, 7 patients healed, and they recovered the pseudoparalysis, but we cannot make and take any conclusions with a high level of evidence regarding this analysis of specific 10 patients selected from a great number of patients. That's the comment.
Okay, question for the second presentation. On the transosseous repair. I have a question for Chiara. First, do you have any cases of migration of the sutures that cut out through the bone? And the second point is, do you have experience of 3 holes repair? Because sometimes when we used to do open repair, we had the risk of fracture of the greater tuberosity when you made your 3 holes in line.
Okay, we didn't have bone failure, the tunnel failure, but I think the most important thing is to choose very well the patient. You have to choose a young patient with no osteoporosis. I suggest to use this technique in patients younger than 65 years old to avoid this risk. And we usually use an X-box configuration with only 2 tunnels. Only in few cases we use 3 tunnels for a triple X-box configuration when you have a quite large lesion. But we usually use those simple stitches or X-box with only 2 tunnels.
Okay, question for the last presentation about AC joint repair in acute setting. Any question? I have a question for Professor Dimakopoulos. I've seen your case series. There was 78 cases, right, of acute repair in a grade 3. So my question is, why did you repair a grade 3?
If we consider that the AC joint with coracoclavicular disruption was there, that was the main indication of going to surgical repair.
Yeah, but how do you know, just from an imaging study, that you have?
Of course.
Yes,
because with the stress, particularly with the stress views, comparing with the right side, we can see from the plain X-rays that it was suspicious for something like this, but it was double the distance after having the stress fractures, which is indicative for rupture of the coracoclavicular too.
Okay, thank you. We are in time, and we leave to the next session to Marco Maiotti, Ettore Taverna. I was going to chair the next session.